We have 3 speakers in our next session. And Al Ferreira is going to moderate for us. So let me introduce Al. Al is a registered nurse who has a 30-year clinical career, including working in critical care, post-anesthesia, perioperative, and orthopedic nursing. And in addition, he has worked as a clinical analyst with information systems and a consultant for 2 software firms, and he is currently the coordinator of the Chordoma Center at Mass General. So there are probably a lot of people in this room who know Al already. He's been with the Chordoma Center for 7 years. So Al is going to moderate this session, introduce our next speakers, and we're going to do question and answer period at the end after all 3 speakers have had a chance to present.
Thanks, Sharon. Our first speaker is Dr. April Zeb. She received her undergraduate degree in biomedical engineering and her medical degree from the University of Wisconsin. She completed her internal medicine residency at the University of Wisconsin Hospital and Clinics and completed the Harvard Interdisciplinary Palliative Care Fellowship at MGH in Dana-Farber. And she joined the Palliative Care Division at MGH in 2015. And her interests include medical education and improving the quality of life and medical care for patients with serious illness. Dr. Zehm.
Thank you. Can people hear me? I'm going to try to stay in front of the podium. So thank you so much for having me. It is an honor to be here with this post-lunch crowd. My name is Dr. April Zeb, and I work in palliative care at Mass General here in Boston. And I've been invited today to talk to you a little bit about my medical specialty and how palliative care might help patients and families facing serious illness. So I think to start this conversation, we first have to know and understand what it is that people facing serious illness want. And when we actually study this and ask, the answers are fairly common sense and may not surprise all of you. People with serious illness want, of course, relief from pain and other symptoms that can come with serious illness. They want to make sure that the burdens on their family are minimized. They want to achieve a sense of control, especially during a time of life where things can feel so out of control. People want to strengthen relationships with the people who are close to them. And of course, they want clear, informed medical decision-making with their doctors and other providers. They want to be sure that they have the right information to be able to make decisions about their care. And so this is what palliative care is all about. So I'm curious, just with a show of hands, how many people have ever heard of palliative care? Okay, many. I'm so happy. This is a term that is unfamiliar to many. So I wanted to take a few minutes and explain what it is that we do. So palliative care is a medical specialty, and it's intended for anyone facing serious illness. Serious illness can come in a variety of flavors. It can be cancer. It can be serious neurological conditions like stroke or ALS. It can be other serious illness, things like heart failure, liver or kidney disease. And so the focus is really to provide relief from the pain and other symptoms that come with serious illness and the stress of a serious illness. And the whole goal is to improve the quality of life for both patient and family. So we really think about families as an entire unit and help make sure that everyone is being taken care of. So I work in an interdisciplinary team. While I'm a physician, my team includes other doctors, nurse practitioners, nurses, social workers, chaplains, psychologists, psychiatrists. It's a whole team of people, and we really work with a patient's other doctors, say their oncology team, to provide an extra layer of support to both patient and family and to the team taking care of them. We like to say that palliative care is appropriate at any age and at any stage in a serious illness, and it really can and should be provided together with curative or life-prolonging treatments. So I wanted to clarify a common misconception about palliative care, and that is that it's the same as hospice, which is not true. I just wanted to say a word about hospice care. Hospice is specialized medical care for people with serious illness who may have a very limited prognosis. It's often provided in patients' homes, but it can be provided in other care settings, such as nursing facilities or hospice houses or even the hospital. It's really intended for people who are focusing on comfort and quality. Oftentimes people opt for their Medicare hospice benefit when the burdens of disease-targeted therapies start to outweigh the benefits. So for example, if there ever comes a time when chemotherapy is not going to buy quality or time, then we start to think about things like hospice. But as mentioned, palliative care is not the same as that. And while a part of what I do every day is hospice, it's really the vast minority. Hospice, or palliative care is a broader umbrella term, and as mentioned, it's best when introduced early and integrated into the plan, even when we're trying to cure disease. So, I, of course, think palliative care is really important, but you don't just have to take my word for it. I wanted to share a study with you that actually looked at whether or not palliative care helps. Certainly, it seems like it would in theory, but is there actually any data? So I wanted to share one of the more famous landmark studies that actually looked at this issue. This was done by Dr. Temmel. She's an oncologist at Mass General Hospital. And this came out in a very prestigious medical journal that you may have heard of called the New England Journal of Medicine. And when this hit the books in 2010, it made national news. There's a lot of media attention for this. You may have even heard of it. So let me tell you what Dr. Temmel did. In her study, she looked at 150-ish patients who had stage 4 or metastatic lung cancer. And when they enrolled in the study, this research study, she split them into 2 groups randomly. One group got standard oncology care, so things like radiation, chemotherapy, pain medicines, anything else the oncologist felt might help. The other group got that exact same care, but they also saw a palliative care specialist at the time of diagnosis. So this could have been a nurse or a nurse practitioner or a doctor. Sometimes they may have seen the palliative care specialty team with their oncology team in the clinic. Sometimes they did alternating visits, kind of depended on what the needs were. But the point is that they got early integrative palliative care. And when they looked at these folks 3 months later and compared, the results were very interesting. So the group who got early palliative care reported overall better quality of life. They also reported less depressive symptoms, depression and anxiety. They also got less aggressive treatments and actually had fewer hospitalizations, particularly at the end of life. And yet, despite this, the most surprising part of this study is that the people in this group lived 30% longer. This was shocking. So, suffice it to say that there have been many other studies done since this initial research study that show that palliative care actually really does have a great deal of benefit for patients and families facing serious illness. So that's the only thing you need to take away from this rather busy slide. And so because the benefits of palliative care are now being more widely recognized, many large, especially academic hospitals, have palliative care teams. So what the heck is it that we are doing in palliative care that is making such a profound impact? So I like to think of our work in sort of 3 domains: the physical, the emotional, and a little bit about medical decision-making and what we call advanced care planning. I'm going to talk very briefly about all 3 of these today. We're not going to have time to go into major detail, but this is just a high-level overview. So first, the physical. So unfortunately, pain is a really common physical symptom for anyone with serious illness. It's one of the more common symptoms for folks facing cancer. When people have early cancer, depending on the study or who you ask, up to 20 to 30% of folks report some degree of pain. And in later stages of cancer, up to 80% of people report pain. I think the most disheartening statistic that I've come across is that when we actually look, up to 50% of people who actually say they have pain say that it's not well managed, it's not well controlled. I think we can and should be doing better because for anyone who has lived with chronic pain, they know that it affects all aspects of one's life: your appetite, your mood, how you're sleeping, overall quality, and your ability to function. So why do people with cancer get pain? Well, pain can come from the cancer itself, particularly when the tumor is pressing on organs, nerves, muscles. It can also, unfortunately, come from cancer treatments that people go through. Things like surgery, radiation, chemotherapy can have side effects. There are many different types of pain, And I will just say that treatment is based on a whole slew of factors, and it can be very complicated. So we're not going to get into details about that, but just know that it can be complex. Because the pain can be complex, the treatment is really best when done in a multimodal approach, meaning we're targeting it from all different kinds of angles. This is a not comprehensive list, but it's long, of the kind of things that we think about for cancer-related pain. Things like anti-inflammatories, things like opioids. Medicines you might have heard of include things like morphine, Dilaudid, oxycodone, or fentanyl. If there's a neuropathic component of the pain, we really want to use nerve-targeting medicines. Equally important to medications are things like exercise and physical therapy, which I think you're going to hear a little bit more about later today. We also think about a whole slew of integrative therapies that can be helpful for pain. Things like acupuncture, Reiki, massage. When things get really tricky, we sometimes even ask our anesthesia colleagues about more invasive interventional therapies and whether or not that would help. Things like nerve blocks or spinal level drug delivery. Now, I will say that oncologists do a really good job of this. I have to give them major props. They do a really good job of this. But because it can be so complicated, when things get tricky, sometimes it can be helpful to have the expertise of a palliative care specialist involved because they bring that symptom management expertise to the table. I want to acknowledge that physical suffering, of course, can be about more than just pain. People who face serious and chronic illness can have a lot of other symptoms, some of which I've listed here, not all. Things like nausea, shortness of breath, trouble sleeping, loss of appetite, really just fatigue, many others. So in palliative care, we really like to think about all of these things and address them. I also want to acknowledge, in the next kind of domain, is that suffering can be much more than just the physical realm. So we know that depression and anxiety are common in cancer, and the stress of serious illness can be great. And so in palliative care, we really try to create a space for people to talk about the things that they're struggling with. So we can check in to see how patients and their families are coping. I think part of the benefit of the Dr. Temmel study, in part, is about people feeling like they're being heard by their medical team, especially about all of the adjustments that they've had to make along the way when they face serious illness. And so we also do a lot of brainstorming and problem solving with patients about the day-to-day stuff that they're facing. Things like, what does it mean to be a cancer patient? How am I going to balance my intensive chemotherapy schedule with my work and family obligations? Who should I be telling about my diagnosis, and when is a good time to do that? How should I be spending my time when my family is away at work? How should I be thinking about taking trips or vacations? How do I manage the goodwill of friends and family? While well-intentioned, it can sometimes be overwhelming. So these are just a few of the things that we think about, and I think a part of this is about regaining control, again, especially during a time when things can feel really out of control. So the last piece that I just want to talk about briefly is that of medical decision-making, that third domain that is a part of my daily work. So I think part of our job is to make sure that we understand what is important to patients and families. This is really individualized, and it differs from person to person. And then we can use our medical expertise and the expertise of, say, the oncology team or other specialists and understand what the options are available. And then together, understanding both of those things, blend them to come up with a really good patient-centered care plan that makes sense for each individual. So to get at the goals and values piece, we often ask patients questions like, how much do you want to know from your team about what's going on with your health or what the future might hold? How do you like to make medical decisions? Who would you like to be a part of this conversation? What are your hopes and your worries as you think about your health? We also do a bit of planning for the future, and we ask questions like, if you were to get sicker, who would be a person who would speak for you on your behalf? Who knows you best? Who would speak on your behalf? Something known as a healthcare proxy. What if you were to get sicker? What do you want your care to look like at that time? And so the answers to these questions really help us understand what's important to you. And then again, understanding the medical options, we can come up with a really good plan. So While we talk a lot about hoping for the best, but also preparing in case things don't go as we hope, the reality is that many people do really well and ultimately become cancer survivors. Sometimes, even when the cancer is behind us, people can be left with residual post-treatment issues, some of which are listed here. At a large cancer center such as MGH's, we actually have a survivorship clinic. And if things are tricky, palliative care remains available to see people in consultation to help think through some of these things. So, I just want to summarize what we've talked about in the last few minutes here. These are the take-home points. So, palliative care is excellent evidence-based treatment. There's research and data that supports this. It is vigorous care of pain and many other symptoms throughout the course of illness. It is care that can be given at the same time as efforts to cure disease or prolong life. It's about empowering patients and families and making sure that their voice and their preferences are heard. It's about tailoring care to individual values. And it's all about living better in the face of serious or potentially life-threatening illness. Palliative care is not giving up. It's not, we have nothing left to offer. It is not in place of curative or life-prolonging treatment, unless that makes sense. It's not the same as hospice, as we talked about, and it is most definitely not just for the dying. So, thank you so much for your attention. We're going to save questions for at the end of all three of our presentations. Thank you.
Okay, our next speaker is Dr. Jayne Donovan. She is from Spalding Rehabilitation Center, which is a facility that many of you who are treated here at Mass General will have had some experience with. She is board certified in physical medicine and rehabilitation. She's a graduate of the Connecticut University School of Connecticut School of Medicine. She completed a residency training at Spalding in the Harvard Medical School program, where she served as a chief resident, and her fellowship training was in spinal cord injury at the Kessler Institute for Rehabilitation in Rutgers. And her clinical interests are focused on caring for individuals with spinal cord injuries and other neurological, an interest in resident and medical education. So.
All right, good afternoon, everyone. I'm excited to be here and have the opportunity to talk to you. So I think, which is fantastic, I think a lot of what I'm going to talk about is going to parallel or echo a lot of what Dr. Zehm just talked about. So I think it's really great that you get to hear from some different specialties may be able to contribute to your care or the care of one of your family members. So my goal today is to introduce you or refresh you on the field of physical medicine and rehabilitation, and then also discuss the ways that perhaps a physiatrist and rehab team can help care for yourself or for your loved ones. I'm going to do the same thing Dr. Zehm did. Who here has heard of physiatry or physical medicine and rehabilitation? All right, so maybe a little bit less. So let's just start with what is a physiatrist. So a physiatrist is a physician specializing in the field of physical medicine and rehabilitation. We care for a variety of individuals, patients with spinal cord injury, cancer, brain injury, stroke, amputation, musculoskeletal disorders, cardiopulmonary disease. So it's a really broad field. Specifically for today, we do have subspecialties in spinal cord injury, which I am subspecialized in, and also cancer rehab. So many times we get to interact with other teams through these disciplines. So what does a physiatrist do? So physiatrists focus on maximizing function. So a little bit different from other medical subspecialties such as a cardiologist or a pulmonologist or a gastroenterologist. We don't have one organ system that we focus on. Instead, we kind of look at all systems and see how that relates to functioning. So over here on the right is an important paradigm for us. So this is the International Classification of Functioning, Disability, and Health from the World Health Organization. And it kind of summarizes how we approach a disease. So at the top, you'll see that there's a health condition. This could be a chordoma or a traumatic spinal cord injury, for example. And then we break it down and look at different domains. So what is the body structure and function? How does that impact activity? And how does that impact participation? So let me break that down for you just a little bit more. So going back, a health condition might be chordoma. The body function and structure might be some gait impairment as a result of that. The activity, the body function and structure might be lower extremity weakness, for example. Activity limitation would be gait disorder, and then participation would be difficulty going to work because of a gait disorder. So we look at not only improving that lower extremity weakness, but also looking at how we can address activity and participation. And altogether, our goal is not only maximizing function, but also improving quality of life. So here's a sample problem list that I use every day. So on the left-hand side, you can see our focus on rehabilitation. We look at things such as mobility, your ability to participate in activities of daily living, thinking, and swallowing. We look at equipment needs, how you're integrated into your community, and also if people are interested in working or going back to work, how can we help with that? The other set of our problem list deals with how do we address these barriers to rehabilitation. And those include things like addressing pain, addressing spasticity and muscle tightness, fatigue, adjustment, your respiratory status, cardiovascular issues, neurogenic bowel and neurogenic bladder is a huge part of our practice, sexual dysfunction, and skin issues. And again, the idea here is to address these so that you can be as functional as possible. So given somewhat limited time today, I'm going to really focus on the left side of this problem list, but when we open up to questions, I'm also happy to answer anything about some of the barriers. One of the things I love the most about my job is I don't work isolated. I'm a part of a team very much like your cancer team or your palliative care team. So on any day, I'm working with a physical therapist, an occupational therapist, a speech therapist, a recreational therapist, a psychologist, a social worker, a case manager, and again, along with your primary medical team. So this is a great question. Where does rehabilitation occur? And the answer really is it depends. For any given patient or family, different rehabilitation centers may make sense. So rehab can occur at an acute care hospital such as Mass General. It can occur at an inpatient rehab facility, for example, Spalding or any other type of acute rehab facility. It can occur at a subacute rehab or a nursing home, a long-term acute care hospital. It can occur at home with home therapists, an outpatient with outpatient physical, occupational, or speech therapy. And also, rehab really is a lifelong thing, so it can occur as part of a home exercise program or even at your local gym. So for everyone, there's no real clear starting point or ending point, and it's really kind of a cycle depending on an individual's needs. So this is an example just of rehab goals. This is more for somebody who has a higher level or cervical chordoma or injury or spinal cord injury. And the whole idea is that depending on an individual's deficits, we start thinking about where do we expect them to be on this spectrum in terms of mobility and doing daily tasks. And we work with the rest of the team to set these goals and work towards them. One of the major things we focus on in rehab is mobility, and we work very closely with the physical therapists for this. And mobility really is how you get from point A to point B so that you can participate in daily activities that you're interested in. Initially, we work on things such as stretching, strengthening, core work, and then also introduce things such as adaptive equipment and other aids. So breaking this down just a little bit more, upright tolerance is kind of our starting point. When somebody's been in the hospital for a long period of time or in the bed for a long period of time, even getting to an upright posture is challenging. So we use different tools to do that. the table with the 3 straps on it is called a tilt table. And that's really just to allow somebody to achieve an upright posture and make sure that their blood pressure is stable while they're in that position. We have other things to the right of that is what's called a standing frame. And somebody who has weakness in their legs that doesn't allow them to stand independently, a standing frame can be introduced that allows some weight bearing. It's great for stretching. It's really good for treatment of neurogenic bowel. And it's also really good for improving mood to kind of be in that upright posture. We also look at other assisted devices for things like transfers. The picture with the bar across is called a Hoyer lift. So that's somebody who initially might not be able to get out of bed on their own. It's a tool that we can use to help somebody mobilize and get out of bed. And the last one, the board there, that's called a slide board. And sometimes we introduce that to patients when they have a hard time kind of standing and adjusting to a new surface, such as a wheelchair or a commode, toilet, or a chair, even at their dining room table. They can use this slide board to help them transfer. So the whole idea is that we have a lot of different devices that we can use to help assist with mobility. Wheelchair mobility is another thing that we look at. I'm not going to go into too many details here, but there are a lot of different wheelchairs available. And one thing that a physiatrist or a rehab team can help you with is if you are using a wheelchair for part of your mobility, we can help you determine what type of chair is best for you. And depending on an individual's needs, what they're interested in doing, different wheelchairs are definitely more appropriate or less appropriate. Many rehab centers also have wheelchair clinics where you can be fit for a custom chair that meets your needs. When we move more towards ambulation, we look at other assisted devices. Some are as simple as things like a walker or loft-strand canes or what are called ankle-foot orthoses, which is the picture on the top right. And I'm sure you guys have also seen in the media, there's a lot of advances in technology and rehab, and that bottom picture is what we call an exoskeleton. So what it is actually pretty much a robot that are strapped onto the legs that can help somebody who's at a wheelchair level stand and ambulate. We recently got approval for home use for one of these. There's many other brands. I'd say it's not mainstream right now, but it's something that will be available more in the future. So it's a pretty exciting time. The next kind of area of rehab that we look at is called activities of daily living. And we work with the occupational therapist on this. Things here include focusing on eating, bathing, grooming, upper body dressing, lower body dressing, toileting. And on the right are a whole bunch of different tools that we can use to help people achieve these activities of daily living. The one with the fork is called a universal cuff. So if somebody doesn't have good finger flexion and they can't hold on to a fork, it's a strap that you can put a fork in there. You could have put a stylus in there, and it can help you do things like eating or access an iPad. So we use different tools to help with these activities of daily living. The last domain of rehab is speech therapy, which focuses on swallowing and cognition. Our speech therapists very much help us with swallow evaluations and teaching individuals about different swallow strategies, with the ultimate goal of making sure somebody's swallowing safely so that they don't have complications such as a pneumonia, and potentially trying to advance that diet. Assistive technology is a big part of what we do. Just as technology is advancing in terms of mobility, it's also advancing in terms of things like computer access. There's great resources now for voice-controlled computer access, for example, or eye gaze. You can use your eyes to move a mouse on a computer screen. So there's a lot of really interesting things that are coming down the pipeline. As part of a rehab clinic, our patients are also, if they're interested in ways in terms of transportation and driving, we can also help them with that. We can help with accessible transportation. If somebody is interested in driving but don't have great control over their legs, we can have them be seen in a driver's clinic where they are evaluated for alternative ways of driving, for example, driving with hand controls. And that driving evaluation really looks at things like vision, spatial awareness, sequencing, and making sure that you're safe on the road. So again, this is just a snapshot of how we can help individuals get back to doing things that they were doing before, maybe in the same way or maybe in a slightly different way. And then this is a passion of mine, adaptive sports. So adaptive sports has a lot of different meanings. Doesn't mean just for individuals in a wheelchair. It's also for individuals who might not have the same level of function that they did previously. So there's adaptive ways to do all of these activities, which to me is always really impressive. Here at Spalding, we do have an adaptive sports clinic that individuals can participate in if they're interested. And I think it's a great resource. I've heard such wonderful feedback from my patients in participating in activities like this. All right. And like I said, today, unfortunately, I'm not going to have an opportunity to address some of the other barriers to rehab and function that I work on in the clinic on a daily basis with my patients, but I'm happy to answer any questions when it's the appropriate time about pain, spasticity, neurogenic bowel, neurogenic bladder, because I think those are really important issues as well. And in terms of resources, AAPM&R is our National Society of Physical Medicine and Rehabilitation. There they have a great tool where you can find a physiatrist in your local area. So if you're not from the greater Boston area or wanted to explore other opportunities, it's a great resource. And similarly, the Association of Academic Physiatrists also has a link to physiatrists in local communities. So thank you guys very much.
Okay, I'm up next. My name, as you know, is Al Ferreira. I'm the nurse coordinator of the Harris Chordoma Center here at the Massachusetts General Hospital, and like just as many of you, I knew nothing about chordoma when I first took this job. So I had to learn as I went on. And we're going to talk a little bit about navigating the U.S. healthcare system. And I think, as most people know, when you first were diagnosed, you suddenly realized it's not like it is on TV. It's very different. So what we're going to talk about is becoming empowered, educating yourself, some hints on how to select a treatment team, and my absolute favorite one, which makes me cry every Friday because that's the day I reserve for it, dealing with insurance companies, working with your treatment team, staying safe, which is important, and I do have some resources for you. One of the things that patients really have to do is to take ownership of your treatment. You can't really just be what is called a good patient, even though that tends to irritate some of us at times, but it's best for yourself to really stand up for yourselves, especially if things don't seem right. And you also need to be willing to question your doctor, and you know that will make them feel uncomfortable. And you need to ask questions until you understand what they're talking about, and preparing for doctor's visits is excellent. As far as learning the specifics of your chordoma, one of the things when you go out on the internet or you're searching anywhere is that it's such a varied disease that every different presentation from clival all the way down to sacral has different symptoms and different treatment impacts. How big is your tumor? And the other big question, of course, is has it metastasized? And I think we heard this morning on the expert panel about the good and the bad part of the internet. You need, before you go out on the internet, decide what you're going to be looking for, whether you're looking for treatments, support, clinical trials, or any of that. Stop searching if it makes you anxious, because you're going to see some information out there that may be old and may make you very, very anxious. And you need to choose your sites carefully. Are they reputable? There's a lot of misinformation on the internet. And the other thing is you need to be sort of careful of paid links. So for example, this is just a Google search page, and you can see that some of these are sort of highlighted by Google, and Microsoft does the same thing. Those are actually links that someone has paid for. Now, I think what we see up here in this case, those are reputable resources, but they don't have to be reputable resources. No one is going out there and saying, is this link really giving you good information? All Google cares about is they get paid for clicks. So it's best to be careful with paid links when you're out on the internet. The other thing is the information that you're looking at on the internet, is it appropriate for your location of tumor? I have seen, and I've had patients talk to me who are concerned about hair loss, sacral patients who have concerned about hair loss with radiation, and well, unless you're worried about the hair on your lower back, it's not a problem. But for clival patients, radiation, it may very well be. So you've got to kind of look at what's on the internet, and is it appropriate for the type of chordoma that you have? Some of the reputable sites is the Chordoma Foundation has done a fantastic job. PubMed is another fantastic resource, and now they're putting more and more free material out on the internet, whereas you used to have to pay for it to get to read some of the journals. The American Academy of Orthopedic Surgeons has some good information on spinal and sacral chordoma. Again, the Chordoma Foundation, their newly diagnosed page is excellent. As far as clinical trials go, sort of the holy grail of clinical trial sites is clinicaltrials.gov. That can be a little bit hard to read, and it can be a little bit hard to filter some of your searches on. So the Chordoma Foundation has actually done a great job in boiling that down on their clinical trial website, and it gets a little more specific to chordoma trials. And of course, Shannon has done a fantastic job as part of the new patient navigation service. I know she's talked to me before, and I think she's done a great job, and that's a great service to avail yourself of if necessary. As far as selecting a treatment team goes, one of the big things about that you've really got to sort of remember is in most cases, you have time to explore all your options. There are a few cases of where you could have acute spinal cord compression, you need to have surgery or radiation immediately to prevent permanent damage, but in the vast majority of cases, you need to take your time to make a decision so you make the right one. And unfortunately, this last one, unless you live near an academic medical center, you're most likely going to have to travel. And unfortunately, that brings costs with it. Your first step, though, is you're more than likely going to be referred to a local specialist. And that can be a problematic visit, primarily because there are some doctors who are absolutely fantastic and will say, I've never seen this in my life, and you really need to see somebody who knows what they're doing. And then there are some doctors who will look at this as a challenge and as something that they really want to do, even if they've never done it before. So you've got to bring questions, bring a notebook and take notes, and bring somebody else, because you're not thinking right at that particular point in time, and somebody else can help with you. Some of the important questions when choosing providers is, are you familiar with chordoma? How many patients have you treated? That's probably the most critical one. And most physicians can give you an immediate response to that. If they haven't, then there's something going on there. Also, talk about the outcomes. What are their outcomes? What are their recurrence rates? And complications. If they're afraid to discuss complications, and there is complications involved in this treatment, so you really need to know that ahead of time. Second opinions are a good idea. Don't see a doctor in the same practice. They're going to tend to be a little bit biased. Don't see a good friend of the first doctor, but get an opinion from an expert. And again, the Chordoma Foundation has done a great job for collecting doctors who deal with chordoma. PubMed also, you can do a search that doctor's name to see if he's actually published anything, he or she has published anything on chordoma. When you're seeking a second opinion, the facility may request records and imaging before you visit. We do that. It's to allow us to prepare. It allows us to kind of know what you need. It may require travel, as we said, and then you need to tell the second opinion what the first doctor said and ask them what they think about it. If the second doctor agrees with the first, then you need to think about who you like more, because personal relationship is a big thing. Training and experience, results, bedside manner, what support services they have available after treatment. Who is more convenient is a big thing. If it's closer to home, it might be easier for you. And the last one is insurance issues, because a lot of insurance companies don't approve treatment out of state. Press the wrong button, sorry about that. And if they disagree, you need to change doctors, consider a third opinion, or you can stick with the original doctor and ask him what he thinks about the first opinion. Dealing with insurance companies, it's always a joy. Some facts when you're dealing with the insurance companies. Chordoma is expensive to treat. No matter what treatment modality you use, it costs a lot of money for them. And the number two thing here is very important to think about. Your insurance company makes money by not paying for your health care, and they will do a lot to not pay for your health care. Your insurance company has a huge bureaucracy dedicated to the entire prior authorization process. And many times you're not dealing with your insurance company at all. You're dealing with a third party that your insurance company is outsourced to. Chordoma is rare, and until recently there were no guidelines. And you're going to know more about chordoma than the healthcare professionals you're speaking with at the insurance companies. You're going to have to do some education and try not to lose your patients. That's very hard for me. You can ask anybody who sits near me on my insurance days. So this is sort of the process that we have to go through to get to treat or even to do an MRI on you. We file a request for the service. It's essentially reviewed by clerical personnel right off. They work strictly off of algorithms. They really don't even know what you're talking about. Then if you're lucky, you get up to the second level, and it's reviewed by a nurse, sometimes a registered nurse, sometimes an LPN. They're still work, though they do have a little bit more power and ability to switch off of their script. They are still working off a strict set of guidelines. Sometimes it needs to get reviewed by an MD, and initial rejection is common. I think if you're talking about proton beam radiation, I would say that I'd say 99% of our patients, and there are some of them in this room, have had rejections on the first pass. And that's just the way it is. It's a knee-jerk reflex because it's expensive. And then if rejected, we have to follow the insurance company's appeals process, which can take time, unfortunately. What can you do? You can ask for a case manager. Case managers are usually professionals who work for the insurance company, usually nurses, and they can actually become your advocate. They can actually become a friend and help you navigate this. During the experts talk, we did hear something about the NCCN guidelines, the National Cancer Center guidelines, and there are the Chordoma guidelines. Unfortunately, they're written by a committee, so they're not specific, but that can be of help when you quote them with the insurance companies. In fact, I just fax them to the insurance companies anytime I file a request for prior authorization. Work with your provider's office, be persistent, fight for the care you need, and if necessary, threat to go public, especially in the fall when they're coming up to time when you can choose your new insurance plan, open enrollment. They don't like public stuff. So that can be. One of the things you need to also think about and to learn about is what to expect after treatment. Everything we do to you, and I'm sure you all, everyone in this room knows, has side effects and has negative effects. So you need to sort of get yourself mentally prepared for what those effects are. For example, and this is, I won't go in depth into this, but what you're looking at is a dermatome. And when you do a resection or you treat a specific area, this shows you a rough picture of the nerves in that area. You know, for example, thoracic spine, lumbar spine, and the nerves that innervate that particular area, and that can be where you will feel treatment effects. So, for example, in sacral surgery, a lot of things is around a lot of focus is around the S3 nerve root because that controls bowel and bladder function. And you can really kind of predict what the treatment result will be based on the level of resection and what the impact is. And if you're interested, you can let me know, and I know that Sharon has this in her library. Don't tell them I gave it to you. Well, just by the way, when you publish these papers, you sign your life away, your rights to them away, so I channel Sharon these little things on the side. We do have one that's on the Facebook page that's looking at quality of life in sacral surgery. We just published a joint study with Memorial Sloan Kettering. Working with your treatment team, developing a good relationship with your treatment team is critically important, and it does require mutual understanding. Most of the physicians I work with and I'm a little bit prejudiced, but they work very hard, and they really do want to be appreciated. Things to understand about doctors is that becoming a doctor takes sacrifice. They are trained to maintain a professional distance, and I think anybody in our business has to do that to a certain extent. Otherwise, you don't do this for a living. External pressures can also stress your doctor's empathy. And you and your doctor have the same goal, the best possible outcome. Working with your doctor and bringing him or her closer, you can help your doctor see you as a person, not just as a patient. Find things in common. And see your doctor as a person. He or she has the same exact emotions that you do. And invest something in the relationship. Empathy does beget empathy. Communicating with your doctor, ask all your options. Ask what are the efficacy, and the risks and side effects of each option, and how will each treatment option affect the quality of life. And that's something we're just really starting to study. When you looked at papers, initially you never would see anything about quality of life. Never, ever, ever see that. And now we are starting to do that. And I'm sure any of our patients have absolutely hate it when I come at them with that iPad. But for the quality of life questionnaire, but it really is important. Let them know about pain and any new symptoms and any side effects. Be sure to get your test results. Don't assume that no news is good news, because to be honest with you, we're human. There are times I'll get results and I will forget to call people. You've really got to stay on top of that and remind us. When you're dealing with your team, the best thing is to get copies of everything. We usually try to give our patients copies of everything, and now since we've gone live with Epic, you get multiple copies of things, whether you want them or not. Operative reports are another important thing to have, especially if you've traveled from out of state to another facility. If there's ever an emergency, having the operative report is very good for the in case of problems like that. Most of our patients will make a notebook, and you have a section for questions and a section for your notes. What if your doctor is difficult? And I'm sure that's happened to everybody. Sorry, guys. Try to figure out why. Is it ego? Would feeding his ego make things better? Is he or she feeling challenged? Try to negotiate and see their point of view also. When you know more than your doctor, that can be a problem. Be sensitive to his ego. Say things like, I'm sure you already know this. When your physician isn't engaged, or your team isn't engaged, ask, do you need him? And is lack of engagement a very important matter? If it is, then get rid of him. And if not, just let it go. Staying safe in the hospital, we'll talk a little bit about this. In the ER, don't be afraid to ask questions if you have to show up in the ER. Don't make assumptions that they know why you're here, that the doctor must be working on. My wife is an ER nurse, so I know all of this stuff in depth. The doctor must be working on my case, because they may not. This may be the correct medicine, and they must know about my allergy. In the hospital, ask about every medicine you swallow. Electronic medication systems are just software written by human beings, and they have their faults, and I can tell you some funny stories from my IS times. If something doesn't seem right, speak up. Be sure your regular medications were ordered, that they weren't neglected. And this is a critical one. Everyone before they enter your room, should use hand sanitizer, and that's a big thing at Mass General, and the nurse managers will follow us around on rounds sometimes to make sure that we do that when we come around. Make sure that your doctors are talking to each other. Find out when rounds are. Unfortunately, surgeons round very early in the AM, and the entire team may not round every day. We have our big rounds on Fridays. These are just some resources, and I can give you these, and there's some links on our website to them that will help you. Join frequent flyer programs. If you're traveling someplace, you might as well get a vacation out of it after your treatment's over. Air travel, for example, corporate air angel networks, that's a great resource. Essentially what they do is they give you space on corporate jets. It's a tax write-off for them, but it's a way for you to get to and from your doctor's appointments. Patient Air Services, which is primarily in the Northeast. Angel Flight, which is another national organization. Lifeline Pilots. Hope Lodge, I'm sure very many people here are familiar with the Hope Lodge. Fabulous facility. Hospitality homes, and some of the hospitals have facilities. The support groups, I'll give Sharon a little plug here for her Facebook page. And Chris, I'm sorry, Chris. So in summary, use reputable websites, ask the same questions of multiple doctors, write everything down, find yourself an expert team that you can work with, the Chordoma Foundation list, treatment center websites, PubMed, ask local doctors for recommendations. Working with your treatment team, stick up to yourself, but be gentle with egos. And if your doctor is being difficult, some of the things that you can consider. Staying safe, always ask questions, get copies of your records, and make sure people wash their hands. And I'd be glad to answer anybody's questions, and you can send me email at this incredibly long email address. Thank you very much. And now we do have some time for questions. So, Sharon.
Hello, can you hear me? Okay. I think all of this was great advice. I'm very lucky living in New York City, and I was at MGH for Proton Beam, that there were so many departments for help with, from massage to acupuncture to arts and crafts, you know. In Memorial Sloan, I've gone to physiatry many times for help, and it's just not available. I help with the Facebook page in every location. So I'm really glad we're covering it and it's being taped. One other thing, and I've had this 12 or 13 years, so I've gone through a lot of insurance companies. Having a case manager can be huge, and many times they are the nicest, sweetest people. I still get cards from some of them, and they're not even working there anymore. We recently had someone come to us just this week who found the Facebook group through a case manager at her insurance company, and she said, well, I liked a page, I think, you know, I'm in, and she walked her through how to get into our private group. And now she's headed in the right direction, which she was not before. So I think all of this advice has been really needed and fantastic, and anyone who's not in the Facebook group, just ask and we'll help you join, but thank you all. I just wanted to say that.
Thank you. Okay, when we...
So this may apply to all of you or one of you, but my husband, his clival tumor caused him to have a stroke in December, which rendered the left side of his body completely paralyzed. Thank God recently he's made an incredible recovery and he's doing really well, but we're to the point where he wants to go skiing again, he wants to wakeboard again. So at what point do I encourage that behavior, and at what point do I threaten to kick him on the couch?
So I can start with that one. So, I mean, I think, so from my perspective, as you guys heard, you know, my goal is to get people back to doing what they love to do. So sooner rather than later is definitely my answer. But I do think there's a couple things that need to be in place, you know. Is he stable from a medical perspective? Has he gotten clearance from his doctors? Is he kind of doing what he needs to do on a daily basis? You know, that's really kind of our starting point. And then once you've kind of met those two criteria, then I say go for it. Sometimes I think it's a lot easier to try with a group or where there's some direct supervision. Some of the adaptive sports clinics are fantastic because they really have expertise. There's different ways of doing things, and preventing injury is definitely important as well. But that would be my advice. You know, make sure that you're medically stable, that, you know, he doesn't have any things that his physician team is worried about worsening with this activity, get some local advice, some help, and then go for it.
Thank you.
Yeah.
Okay, over here.
Al, I want to just cite, you probably don't remember me from 2010, but I just wanted to preface my question with a statement that everybody in this room don't take for granted that what we've been told here exists here in Boston, exists all over the United States. I mean, thank God for Al. When I was first diagnosed, I called MGH and I said, I don't know what to do with the pain. And Al said, well, you know, we did pretty well with gabapentin. And I started with gabapentin even before I began treatment up here. And you really saved my life, so I wanted to thank you for that.
Thank you.
However,
Thank you.
my question, I come from a very small town. I come from Manhattan, New York. I came up here and was diagnosed with a recurrence on January 11, at which point I was told to find a good palliative care doctor in New York City. It is now what's today, July, what?
16th.
I have still not been able to find a palliative care doctor in the small town that I come from, New York City, so I can only imagine what other people who come from smaller towns, other cities, must go through in order to obtain the kinds of wonderful services that you just described. I wonder whether you could tell the rest of us who come from small towns, where palliative care, by the way, in New York is always associated with treatment in that particular hospital. So if you are on a watch and wait type of treatment, which is increasingly being prescribed, there's no hospital that is going to provide you with palliative care. So my question is, could you give advice to those of us who do not have access to the wonderful services that are available here in Boston?
That is a great question. Thank you so much. And I'm sorry that I didn't address it before, because you bring up an excellent point that there is a nationwide shortage of palliative care specialists right now, and it is expected to continue for many years, decades. There are an increasing amount of fellowship programs that are being developed to address this, but the issue is real for the here and now. So a couple of thoughts. One is that I actually think that starting with your primary care doctor locally about who they often refer to is a great first step. You know, I may not know the palliative care team in Iowa or California, but your primary care doctor may know who to refer to. And if it's not specifically a palliative care specialist, they may be able to refer you to other specialists who do palliative care-like things, like an anesthesia or a pain specialist, for example, if the pain is the major issue. So start by asking your primary care team or your oncology team who they recommend locally. The American Academy of Hospice and Palliative Medicine, so AAHPM, is our national society, similar to the one shared about the PM&R folks. So that may be a resource to find a local specialist, something that I would point you all to. The other thing that I will just say is that while palliative care is a medical specialty, it's also a philosophy. And so many oncologists and even primary care doctors do their own palliative care. They may feel totally comfortable prescribing pain or nausea medicine or helping get you in touch with a local masseuse or, you know, Reiki specialist, whatever it is that you need. So again, I think starting local and asking about those things is critical. Does that answer the question? I guess the other thing I will say, just to piggyback off that, is that sometimes actual local hospices, community hospices, have palliative care programs. It doesn't mean that you're going to enroll in hospice with them, but it may be that they actually have a palliative care team as part of their hospice agency, because hospices are really, those are universal and can be found even in small communities, small local communities. So that would be another thing I would suggest. Mm-hmm.
Add a comment because I really liked what you just said about it's a philosophy. And something that we kind of stumbled into, my daughter's the Chordoma patient, but my primary care doc, who then became her primary care doc, is in family practice. And I want to just give a little shout out for family practice because the family practice doc recommends acupuncture, refers for a whole range of complementary medical and other supportive services. And so sometimes you may want to think about who's your primary care doc and are they providing the kind of support you want?
Thank you.
Okay. I do have a couple of questions. And Jayne, and this is something that is really sort of hitting the focus today with the whole national emphasis on narcotics, and that is what options are available to help with loss of function due to side effects from treatment. Is there any new research being done in this area? And I know a lot of our patients have a lot of, and I'm sure you've seen them over when they get over to Spalding, have some serious dysfunctions.
Yeah. So, I'm sorry, the question is loss of treatments?
What options are available to help with loss of function
Yeah. So,
and treatment?
so there's a variety of things. Unfortunately, as of right now, we don't have a pill necessarily for, here's this pill and we're going to make you stronger or help with new sensation. Maybe that's in the future, but as of right now, we don't really have it. In terms of treatments, it's really kind of what I went through, starting working with the rehab team, working with therapists to get stronger, and then also looking to see what are ways that if the body doesn't change to be able to do things that you, in the same way you were able to do it before, how can you adapt and do those same activities, but maybe in a different way? In terms of research, there's a lot of research now in terms of the benefits of therapy, benefits of alternative pain control, benefits of working with an interdisciplinary team, and how that can help improve function. And then, like I mentioned, there is also this very exciting world of technology and rehab, and there's a lot of research going on with that right now as well.
Okay. And April, this is something I know all of our patients suffer from. And what pain management options are available specifically for nerve pain? I think both of you could comment on that one. It's a big problem for
Specifically
most
for nerve
patients.
pain.
Yeah.
Great question. I didn't talk specifically about this, but it was one of the long list of things that I showed on the pain slide. There are a lot of things that can be done to help with nerve pain. Some medicines that some of you all may be familiar with are things like gabapentin or Lyrica, Cymbalta, which if you actually look it up is actually an antidepressant, but it has great nerve pain properties and can help with that. Believe it or not, sometimes opioids can help with nerve pain, specifically methadone, which is something that a lot of people don't think about. And when I say methadone, people get a little nervous because they often think about it in the context of opioid addiction, but we use it in very different ways in the pain clinic to help with nerve pain. When things get really tricky, there are sometimes interventional techniques, so things like nerve blocks or steroid injections locally along the spine that can be helpful with this. If things get really tricky, there are even things like spinal level drug delivery, so things like epidurals, which many people are familiar for when pregnant ladies are giving birth, but epidurals can be used more long-term, like over weeks to months, and if helpful, sometimes we even think about intrathecal pumps that actually constantly deliver local medicine around the spinal cord. So that's kind of advanced stuff that we often start with medicines first, but the point is that there are a lot of things to consider and a lot of options for people.
Okay. How about I'm sorry, back up there.
For pain specifically, or for just in general supplements? Neuropathy, yeah. There's always research done, and it seems like every week there's something new that they're working on. Not opposed to supplements. I think the caution that I often give my own patients when they're thinking about supplements for anything is just to know that Unfortunately, a lot of times we don't actually know what is going into these vitamins or supplements. It's often not something that's actually regulated by, for example, the FDA, that does really strict, stringent testing of any kind of drug before it hits the market. And so if a patient finds something that's helpful to them, as long as I don't think that it's unsafe, I'm all for it. But I just caution people before, especially before they're going to spend a lot of money sometimes on these supplements or things that you can get, through the internet or even at the local drugstore or herbal remedy store, to just know that sometimes we don't actually know what's in these things, and what's on the label doesn't necessarily reflect what's in the pills. So just use caution and common sense, I would say.
I would also double check with your primary care team, primarily because there's certain supplements that will interact with the treatments that you're getting. For example, there are some vitamins and antioxidants and things that will have a negative impact on the effect of radiation, because radiation actually depends on some oxygen being there. So just double check with your treatment team.
Great point.
Emily.
I had a question. So I was on methadone for many months, and it seemed weird, and I thought it was funny telling all my friends I was on methadone. But it was a great drug and very helpful. And even being on a very small dose, I found it very difficult to get off of. I had a lot of what I felt like physical side effects, and I was curious about what kind of in palliative care, what programs you have for helping patients once they no longer need these treatments, getting off of them and feeling safe and comfortable doing so. Mm-hmm. And also, I guess, just like, is there research that is going on for that, for safely and helpfully getting patients off these incredible drugs, but also scary drugs?
Mm-hmm. You're pointing out that, and as it's come up before too, everything that we do in medicine has side effects, right? And so it's always a balance of the risks and benefits of things. There's a lot of stigma out there right now in the kind of mainstream press about opioids in general. It seems like every time you turn on the news, we're hearing about opioid-related deaths or the heroin epidemic, et cetera. But really, for cancer-related pain, opioids remain a really important part of that treatment for many people. Not all, but many. So always doing this under the supervision of your oncology team or a palliative care team is critical. And it is true that these are medicines that generally shouldn't be stopped cold turkey. They should be tapered down in a slow, careful, thoughtful way under medical supervision. And it's usually possible when the source of the pain has gone away that you're right, many people then don't need these kinds of medicines, which can have side effects. I guess my advice would be to make sure that it's done under medical supervision so that we're doing it in a careful, thoughtful way, as quickly but as safely as possible to taper down these medicines.
We do have time for one more question, if there is anybody out there who wants to, yeah. Okay, I guess we are set, and thank you to our guests from